Neonatal polycythemia is a condition where a newborn's hematocrit exceeds 65%. This results in increased blood viscosity or thickness, which can impair blood flow, tissue perfusion, and oxygen delivery. One primary cause of neonatal polycythemia is increased erythropoiesis, the production of red blood cells. Intrauterine hypoxia due to maternal conditions such as diabetes mellitus, chronic hypertension, or smoking can reduce oxygen delivery to the fetus. To compensate, the fetal kidneys release erythropoietin, a hormone that stimulates the bone marrow to produce more red blood cells, elevating the hematocrit. Thyroid dysfunction can also cause polycythemia. Hypothyroidism reduces metabolic activity and oxygen delivery to tissues, stimulating erythropoietin release. Conversely, hyperthyroidism increases metabolic demand and oxygen consumption, also driving red blood cell production as a compensatory response. Genetic abnormalities such as trisomy 21, 18, or 13 can dysregulate erythropoiesis. These conditions lead to overproduction of or an exaggerated response to erythropoietin, which leads to increased production of red blood cells and elevates hematocrit. Another mechanism causing polycythemia is increased red blood cell transfusion into the baby. Delayed cord clamping, where the umbilical cord is clamped 30 to 60 seconds after delivery, allows more blood to transfer from the placenta into the newborn. While this is beneficial for iron stores, this additional blood volume can elevate hematocrit levels and cause polycythemia. In monochorionic twins who share a placenta, there can be an abnormal connection of blood vessels within the shared placenta that can lead to twin-to-twin transfusion syndrome. The donor twin becomes hypovolemic, while the recipient twin receives an excessive blood volume leading to polycythemia. Clinically, neonatal polycythemia may present with a plethoric or ruddy complexion. Hyperviscosity from thickened blood can impair tissue perfusion, causing cyanosis, respiratory distress, or abdominal distension. Hypoglycemia due to increased glucose consumption by the excess red blood cells can result in irritability and jitteriness. However, many cases are asymptomatic as compensatory mechanisms like increased cardiac output maintain oxygen delivery. Lab findings show hematocrit greater than 65%, hyperbilirubinemia due to increased red blood cell turnover, and hypoglycemia from elevated glucose consumption. These findings confirm the diagnosis of polycythemia. Management depends on the severity of symptoms. Mild cases are treated with intravenous fluids to improve hydration and hemodilution, and glucose supplementation for hypoglycemia. Severe cases with significant hyperviscosity may require a partial exchange transfusion, where a portion of the infant's blood is replaced with normal saline or plasma to reduce hematocrit and improve blood flow. In summary, neonatal polycythemia arises from increased red blood cell production or excess blood transfer. It can lead to hyperviscosity and complications of poor perfusion, but timely diagnosis and appropriate management ranging from supportive care to partial exchange transfusion ensure better outcomes for affected neonates.